Hello friends. So let us jump right into the discussion of radiology and related questions in this recently conducted INI-CET May 2025 exam. So a fairly straightforward question. They asked you that there's a 35-year-old female patient presented with colicky pain diagnosed to have ureteric colic due to a renal stone. Which of the following is the best diagnostic investigation? I know most of you already know the answer to this. This is pretty straightforward, but let us quickly in the next 2 to 3 minutes do a very in-depth comprehensive discussion of acute renal colic, the imaging manifestations and the imaging protocols. So if a patient comes to you with acute lumbar region pain radiating typically from loin to the groin, that is the very typical presentation pattern, along with burning or frequent micturition, right? What is the suspected diagnosis? The suspected diagnosis with this history or clinical capsule is an acute renal colic. So when you suspect acute renal colic, clinically, what is the first investigation that you do? Well, the initial investigation, which is most commonly done now, is USG, readily available, can be quickly done, is the investigation of choice for detection of hydronephrosis, right? If USG is not available, or in the olden days, what they used to do was an X-ray KUB, but X-ray KUB has poor sensitivity for detection of calculi. So what will you see if you do a USG or an X-ray KUB? Well, on an X-ray KUB, you may be able to see directly the renal calculus. If it is a ureteric calculus, you will see it somewhere along the course of the ureter. Certain specific appearances, right, related to renal calculi is a typical cast-like structure filling up the entire renal pelvic system. What is this called as? So this is a renal calculus. Whereas when the calculus shadow appears as if it is a cast completely filling up the renal pelvic system, this is what is called as a staghorn calculus. Usually these are triple phosphate or struvite calculi. Right now, if you do a USG, on USG typically a calculus is seen as an hyperechoic focus with a dense posterior shadow. Maybe in the next upcoming exam they give you an image like this, but this is a non-obstructive renal calculus because there is no hydronephrosis in this kidney, as you see here. If this calculus is dislodged here, goes and gets impacted in the ureter somewhere, right, there will be an obstruction to the pelvic system and ureter. So you see the dilated pelvic system as well as the dilated ureter. So this patient has a hydronephrosis along with a hydroureter, right? So this is the spectrum of findings that you expect to see when you do a USG or an X-ray KUB in acute renal colic. Now, what is the, so this is a non-obstructive renal calculus, this is an obstructive calculus with hydronephrosis. What is the best investigation or investigation of choice for renal or ureteric calculi? Remember, it is a non-contrast CT, and that was the answer in this particular, for this particular question in the exam. Well, contrast is not required per se to look for calculi, and hence non-contrast CT is considered to be the investigation of choice. So if you do a non-contrast CT, you will be able to see the renal calculus here, as you can see within the renal pelvis, right? A calculus within the urinary bladder, a calculus within the urinary bladder takes a very peculiar shape. This is what is called as a jackstone calculus or a jackstone vesicle calculus. A calculus impacted within the ureter has the edematous ureteric wall surrounding it on all sides. So there is a calculus at the center with a soft tissue rim around it. This is what is called as the soft tissue rim sign of a ureteric calculus. That is how a typical ureteric calculus looks like. There is a soft tissue rim around it. This soft tissue rim is formed by the edematous ureteric wall around it. Right. So let us quickly, finish off with some clinchers related to urolithiasis. The most common calculus, remember, are usually calcium oxalate calculi. The hardest calculus is usually a cystine calculi, right? These calculi therefore cannot be treated with extracorporeal shock wave lithotripsy or ESWL because they are very hard. They will not get fragmented. Radiolucent calculi, so calculi that you will not see on X-rays, these are usually pure uric acid calculi or certain medication calculi such as indinavir calculi or pure matrix calculi. So these are the calculi which are considered to be radiolucent. Now a specific question was asked in one of the exams as to which are the CT occult calculi. So of these radiolucent calculi, the indinavir calculi and pure matrix calculi are considered to be CT occult calculi, so they will not be seen even on a CT scan, right? Now, this tube, so certain spotters related to calculi, so this is a tube which has been passed percutaneously into the kidney. So this is what is called as a percutaneous nephrostomy tube, or percutaneous nephrolithotomy can be done, and the calculus can be retrieved. So there's a big calculus in the kidney to drain the kidney, right? To drain the urine, to establish a urine output. A percutaneous nephrostomy tube has been done. Another method to treat renal calculi is an extracorporeal shock wave lithotripsy to fragment large calculi. Once the large calculus has been fragmented into smaller fragments, so that those smaller fragments don't get impacted, usually a double J stent or a DJ stent is placed. So you can see there's one J, loop in the renal pelvis, one J loop within the bladder, and it is this double J stent which is going to help to drain the urine. These small calculi fragments, they get lined up along the length of the double J stent, and this is what is called as the Steenstrasse appearance. Steenstrasse in German means a stone street, a street which is made up of multiple small stones. So these calculi which line up along the ureter alongside the DJ stent, this is what is called as the Steenstrasse appearance. So we have seen the PCN tube, the DJ stent, and the Steenstrasse appearance related to renal calculi. Now, let us quickly cover certain complications of obstructive uropathy. Maybe next time in the upcoming NEET PG exam, they ask you about this. So, patients may present with acute pyelonephritis, known case of renal calculi, present with fever, elevated total leukocyte count, abundant pus cells in the urine. You do imaging on a CT scan, the kidney is markedly enlarged, shows heterogeneous enhancement, perinephric fat stranding is suggestive of an inflamed or an infected kidney, an infected renal parenchyma, infected kidney secondary to calculus disease. This is acute pyelonephritis. A very severe form of renal infection is what happens in diabetics and immunocompromised patients. This is what is called as emphysematous pyelonephritis, typically happens in diabetics or immunocompromised patients. Well, this is infection caused by air-forming microbes, right? So in this condition, you will see that in the renal fossa, there is extensive dirty black mottling. Why is it black? Because what appears black on an X-ray or CT is nothing but air. So infection with air forming microbes results in a lot of air interspersed within the renal parenchyma or tissues. So this is what is giving rise to that black mottled dirty appearance in emphysematous pyelonephritis. Another typical condition is xanthogranulomatous pyelonephritis. Well, this is because of chronic renal calculus disease with superimposed infection from Proteus or E. coli, typically presents with a central dense calculus and multiple round, collections in the renal parenchyma. So this looks like a bear paw. So this is what is called as the bear paw sign. So this is what you need to know as far as urolithiasis is concerned. So this was a patient of acute renal colic. What is the best investigation? The best investigation in acute renal colic we have seen is a non-contrast CT scan of the kidney, ureter, bladder, which will very beautifully demonstrate the calculus. USG is the initial investigation. Contrast is usually not required to demonstrate calculi. Ureteroscopy is basically used to treat the calculi, fragment them and retrieve them out. So this is the answer to this question. It is non-contrast CT KUB. A 15-year-old boy presents with recurrent seizures. A CT is done with the following finding. So what is the finding here? So they have asked you about the diagnosis here. The finding that you are able to see here is a ring enhancing lesion. So this is a ring enhancing lesion. So ring enhancing lesion, what is a ring enhancing lesion? So ring enhancing lesion is a lesion within the brain parenchyma that looks like a ring. But why does it indeed look like a ring? It looks like a ring because along the periphery of the lesion, you have the viable tissue which enhances, and this is the peripheral enhancing rim. But why does the peripheral area enhance and why not the central portion? Is because the central portion is not viable. It is non-viable tissue, non-viable area, which is the central non-enhancing area. Now, I could just simply give you a big list of differentials to consider when you see a ring enhancing lesion, right? But I will not do that. Rather, what we are going to do here in the next few minutes is that we are going to have a comprehensive, clinically integrated discussion of ring enhancing lesions, where we study ring enhancing lesions as a combination of a very typical clinical presentation or a scenario along with the classic imaging findings. And when you combine both of them, you will arrive at a peculiar diagnosis, and that is what is going to help you in your exams. So let us start doing this. So first, ring enhancing lesion. Look at the clinical profile carefully. There are signs of infection. So there is fever, headache, seizures. This is a known case of pulmonary TB. This is a very, very important clue. And there could be signs of meningitis. So known case of pulmonary TB, while the infection could spread to the CNS, causing tubercular meningitis, right, or tubercular infection of the brain and the meninges. There are signs of meningitis which are present. What do you see on imaging? Imaging, you see diffuse basal enhancing exudates. All the basal cisterns at the base of the brain are filled up with infective exudates. You give contrast and they are going to enhance in a significant manner. And in the brain parenchyma, you see multiple conglomerated ring enhancing lesions. Can you see multiple ring enhancing lesions? Like bunch, they are as if they are bunched together, they are conglomerated together. This is a very, very peculiar feature of tuberculosis infections involving the brain, and these ring enhancing lesions that you see in tuberculosis are nothing but tuberculomas. So very typical clinical presentation, known case of pulmonary TB with signs of meningitis. Tubercular meningitis typically has diffuse basal enhancing exudates. As you can see here, all this white area at the base of the brain is the basal enhancing exudates, and multiple conglomerated ring enhancing lesions. This is very typical for tuberculomas as a ring enhancing lesion. Now, there is a patient who presents with headache and seizures, right? Usually, there could be fever, there could not be fever, there is no history of pulmonary TB infection, no signs of meningitis, but there is a ring enhancing lesion. What is so peculiar about this ring enhancing lesion here is that there is an eccentric dot within that ring enhancing lesion. So when you see a ring enhancing lesion and you see an eccentric dot within it, this eccentric dot, friends, represents what? It represents the scolex of the parasite, and hence once you see this dot, you are able to clinch the diagnosis. And what is the diagnosis? It is Neurocysticercosis. This sign, in fact, with a ring enhancing lesion with a dot within it, this is what is called as a cyst with a dot sign. So cyst with a dot sign, right? So this is what is that dot, that is the scolex of the parasite. So this is very typical of Neurocysticercosis. Now, you have a young or middle-aged patient who presents with some infection or reservoir of infection in the nearby structures such as the paranasal sinuses. So the patient may have sinusitis, or there could be chronic ear infections or ear discharge pointing towards CSOM. So this is that adjacent source of infection or reservoir of infection. The infection spreads from this primary source into the brain. So the patient now presents with fever, headache and altered sensorium. And what do you see on imaging? On imaging now, if the primary source of infection was in the frontal sinus, you'll see a lesion within the frontal lobe. If the infection was within the ear, you'll see a lesion now within the temporal lobe. So you see a temporal lobe ring enhancing lesion. They could give you a diffusion weighted image where the lesion appears bright or hyper intense. This is what is called as restricted diffusion on DWI. So if you see a ring enhancing lesion with restricted diffusion on DWI, it is an abscess or pus within it. So this is a diagnosis of a brain abscess. So typically signs of infection with an adjacent source of infection or a reservoir of infection from which the infection has spread to the brain. So this is what creates the ring enhancing lesion of brain abscess, right? Bright on DWI, so restricted diffusion on DWI is another clue to diagnose brain abscess. Now see, another very typical clinical clincher or capsule. This is an HIV positive patient with a low CD4 count. So whenever you see an HIV positive patient with a low CD4 count, you should be thinking of what? You should be thinking of, yes, opportunistic infections. Correct. So you should be thinking of opportunistic infections. Patient presents with fever, malaise, headache, and what do you see? You're able to see ring enhancing lesions within the basal ganglia or at the gray white matter junctions. And there is a very typical appearance to those ring enhancing lesions. They have a target sign or a concentric target sign or an eccentric target sign. You see something eccentrically within it. So this is not a dot within it. It is an area of enhancement within it. So in an HIV positive patient, you see a ring enhancing lesion with an eccentric target sign. What is that most common? Opportunistic infection that affects the brain in immunocompromised patients. Yes, it is toxoplasmosis. So toxoplasmosis is the commonest opportunistic infection that involves the brain in HIV positive patients. You see a ring enhancing lesion in an HIV positive patient in the brain, you think of toxoplasmosis. Now, you see a middle-aged or an elderly patient who presents with seizures, focal deficits, no signs of infection here. There is a very irregular appearing ring enhancing lesion which shows a thick peripheral rim of enhancement with central necrosis. So, no signs of infection, no fever. You see a thick rim of enhancement around it as if this is the thick rind or rim of tumor with a central area which is not enhancing. Why? Because there is necrosis at the central portion, which tumor within the brain has the hallmark of central area of necrosis. It is a very high grade tumor or a high grade glioma. This is what is called as glioblastoma. So what is the radiological as well as histopathological hallmark of a grade 4 or a high grade glioma or a glioblastoma? It is a central area of necrosis. So that area of necrosis does not enhance, whereas the peripheral thick rim of tumor usually enhances. It can cross across the midline, across the corpus callosum, in which case it is what is called as the butterfly. Yes, it is called as the butterfly glioma. Right? So this is what is a high grade glioma or a glioblastoma. You see an elderly patient with a known case of primary malignancy. So once you have a known case of primary malignancy or cancer and you see a ring enhancing lesion within the brain with seizures, focal deficits, what do you think of? You think of that primary tumor spreading into the brain. So then you think of metastasis. So do you realize what we have done with ring enhancing lesions? Instead of simply discussing them as a list of ring enhancing lesions, which would make it very factual, very difficult to remember and very boring too, we have actually studied them as a with a clinically integrated approach where we look at certain golden points within the clinical history, right, that are going to help us make a diagnosis. And we have also looked at the typical imaging pattern like cyst with a dot, conglomerated ring enhancing lesions, right, eccentric target signs in an immunocompromised patients. And we put both of them together, you will be able to make a good diagnosis of ring enhancing lesions. Well, the question in your exam was based on neurocysticercosis, that dot within that particular lesion. Quickly, let us cover another point related to neurocysticercosis. This is what is called as the Escobar's staging of neurocysticercosis. Neurocysticercosis is classified into 4 stages. The acute stage is called as the vesicular stage. This is the stage in which there is no edema, no inflammation, no enhancement, because the cyst has just happened within the brain. The brain or the body is yet to react to it. As the parasite degenerates and the parasitic antigens diffuse into the brain parenchyma, this leads to the early subacute stage. This is what is called as the colloidal vesicular. This is called as the colloidal vesicular stage. Now, because the parasitic antigens have diffused into the brain parenchyma, these are foreign antigens, the body is going to react to it very strongly, and therefore there is going to be maximum edema, inflammation and enhancement in this early subacute stage, that is colloidal vesicular stage. As the body has lodged an immune response as time passes, we pass on to the late subacute stage. This is what is called as the granular nodular stage. This is the stage where there is a decreasing trend of edema, inflammation, enhancement, because the inflammation is going to decrease as the immune system acts over the parasitic antigens. Ultimately, the parasite is killed, phagocytosed, the antigens are taken away. What remains at that site in the brain is a tiny calcific focus of a dead calcified parasite. This is the chronic stage or the nodular calcified stage. Nodular calcified stage or chronic stage of neurocysticercosis. This again does not have any edema, inflammation or contrast enhancement, right? So the image in your, so another important classic image which could potentially be asked in your exams is this. This is neurocysticercosis, but not affecting the CNS, but affecting the muscles. So this is called myocysticercosis because it affects the muscles, and these cysticercosis granulomas within the muscle get calcified they give rise to these elongated calcifications within the muscle, which can be seen on X-ray. So this is a spotter, many times it is asked. This is called rice grain calcification of Myocisticercosis. So maybe they give you, along with the CNS image, they give you an image like this that will add value to their particular diagnosis. So this is rice grain calcification of cysticercosis affecting the muscle. So Myocisticercosis. So the image in your exam was a ring enhancing lesion. There was a ring enhancing lesion and there was a dot within it. We have studied. This dot represents what? It represents the scolex of the parasite, and hence the answer to this particular question, the clincher, is neurocysticercosis. Right? Cyst with a dot sign of neurocysticercosis. Yes. A 12-year-old was brought with rigidity and cognitive impairment. A T2-weighted MRI was showing an eye of the tiger sign as shown in the image below. Which of the following is the cause? Now, eye of the tiger sign, right, is something like this. So, what is this? Let us try to understand this first. Identify this dark appearing area on this MRI. Can you see that? What is this area? Can you identify this? So, this is the, yes, this is the globus pallidus. Now, why is the globus pallidus appearing dark? It is because there is iron deposition which has happened within the globus pallidus. But it's not uniformly dark. Why? Because if you look at these areas within the globus pallidus, it is appearing bright. So dark appearing globus pallidus is because of, or hypointense appearing globus pallidus is because of iron deposition within it. But what is that white area? That bright appearing area within the globus pallidus is because of some amount of gliosis which is happening within it. So this dark appearing globus pallidus because of iron deposition with a central bright area due to gliosis is likened to the appearance of the eye of the tiger. So this is what is called as the eye of the tiger sign, seen in what? Seen in a peculiar condition which is called as Haller-Walden-Spatz disease or syndrome. Now Haller-Walden-Spatz disease or syndrome is also called as pantothenate kinase associated neurodegeneration. So this is also called as PKAN, pantothenate kinase associated neurodegeneration or pantothenase kinase deficiency. So this is a feature which gives rise to neurological signs and symptoms along with a typical eye of tiger sign. What is that? We have just seen that on T2-weighted MRI. So this is Haller-Walden-Spatz syndrome disease or pantothenate kinase associated neurodegeneration. These typical miscellaneous spotters involving the CNS is a very favorite topic, especially in INI-CET exams. Let us quickly go through a few more CNS spotters, miscellaneous conditions. So this was something which was asked, a couple of years back in an INI-CET exam. If you see a typical peg-shaped, elongated cerebellar tonsil, which is herniating down into the cervical spinal canal, and as a result of it, you can see this syrinx which is forming inside the cervical spinal cord, then this finding of just a peg-shaped triangular cerebellar tonsil along with a spinal cord syrinx is what is seen in Arnold-Chiari type 1 malformation. So a peg-shaped cerebellar tonsil along with syrinx within the cervical spinal cord is an Arnold-Chiari type 1. What is Arnold-Chiari type 2? Arnold-Chiari type 2 is a combination of lot of abnormalities. So there is a small sized posterior fossa. You see a vertical, cascade of, or a peg-shaped tapering cerebellar tonsil herniating down. You see a corpus callosum abnormality or a dysgenesis of the corpus callosum. You see abnormalities of the ventricular system, dilatation of ventricles, typically in the posterior parts, teardrop shaped ventricles. This is also called as colpocephaly, along with a open spina bifida in the lumbosacral region. So a combination of all of these abnormalities is what is called as an Arnold-Chiari type 2 malformation. Yes, if you see an abnormality involving the posterior fossa, where you see the fourth ventricle is enlarged. Posteriorly, it is communicating with a big cystic space in the posterior fossa. What is this? An enlarged posterior fossa with an upward displacement of the torculi with a large cystic space in the posterior fossa is a malformation of the posterior fossa. What is this called as? This is what is called as the Dandy-Walker malformations. Another CNS spotter which could potentially be asked. Yes. Now, if you look at this classic appearance of the brainstem and the superior cerebellar peduncles, what does this look like? This looks like a molar tooth, isn't it? So, this is the molar tooth appearance seen in what? Seen in Joubert syndrome. So, it is spelt as Joubert, but it is actually pronounced as Joubert syndrome. It is an abnormality involving the cerebellar vermis. There is elongation of the superior cerebellar peduncles, which gives rise to a typical molar tooth appearance in Joubert syndrome. When you see a cleft in the brain parenchyma, which extends from the surface of the brain right up to the ventricles, this cleft within the brain is what is a feature of schizencephaly. It could be a closed lip schizencephaly as in this case, but if they are widely separated, it is called as an open lipped schizencephaly. So, the eye of tiger sign because of the gliosis within the globus pallidus, right? Because of the iron deposition within the globus pallidus, making it appearing dark or hypointense, and the bright appearance being because of gliosis. This particular appearance of eye of tiger sign or the tiger eye sign is a feature of pantothenate kinase deficiency, right? Wilson's disease usually gives rise to the face of panda appearance. Huntington's chorea gives rise to a boxcar shaped ventricles. Krabbe's disease mainly involves the thalamus. So these are very typical appearances involving the CNS. Eye of tiger sign is Haller-Walden-Spatz syndrome or pantothenate kinase deficiency. Yes. So a 74-year-old female, so an elderly female, so this is a clue here, complains of low backache. Is there any history of trauma that they have given here? No. So there is no history of trauma that they have given here. She complains of low backache. Stir sequence is shown here. This typically shows the Honda sign or H sign. What is the likely diagnosis? Before we come to this particular appearance or sign, I want you to quickly revise the concept of stress fractures. So stress fractures could be fatigue fractures or insufficiency fractures. So stress fracture happens when there is a mismatch between the stress exerted onto a bone and the strength or the density of the underlying bone. So if you see that there are excessive stress, there is an excessive stress which is exerted on a normal bone, this leads to what is called as a fatigue fractures, which is usually seen in athletes or army recruits because of the excessive physical activity that they may undergo. Whereas if a normal stress is exerted on a weakened or an abnormal bone, this is what is called as an insufficiency fracture. Just imagine this, an elderly female with severe osteoporosis, right? The bone is abnormal, the bone is weakened. In such a case, even a normal stress on such weakened bones may give rise to fractures. This is what is called as insufficiency fractures. And this sacral insufficiency fractures is what the question was asked upon. We will come to the imaging sign, which is the Honda sign or H sign. But before that, let us quickly look at the associated conditions, some important points related to the sacral insufficiency fractures. So sacral insufficiency fractures are most commonly associated with osteoporosis. Although most commonly associated with osteoporosis, they could also be associated with osteomalacias, right? Any condition which weakens the underlying bone, say rheumatoid arthritis, Paget's disease, diabetes mellitus, so on and so forth. How does it present with? It typically presents in an elderly female. It typically presents in an elderly female who presents with low backache, as was the case in the question, but with no history of trauma. So trauma is not there, no history of trauma. right? Elderly female consistently presenting with long-standing, prolonged periods of low backache, no history of trauma is how it typically presents with. Typical imaging finding, right, is seen on two imaging modalities, that is a technetium labeled MDP bone scan or on an MRI. So radiographs are usually not sensitive in the early stages. CT scan can show the findings, but again in the late stages, what can typically present or what can typically pick up the signs in an early stage is either a bone scan or an MRI. So you can see the appearance here. The defect within the bone is usually along the sacral ala. So there are vertical fractures along the sacral ala, right, with some extensions going across the sacral body, and what creates that typical H sign or Honda sign, as you can see in this technetium labeled, technetium 99 metastable labeled MDP bone scan. You can see here there is an increased uptake of the radionuclide at the site of the fracture. You can see two vertical limbs and a horizontal extension. This is your H sign or Honda sign. And this is a STIR, short tau inversion recovery MRI sequence. What it shows us is basically the bone marrow edema. So because there is a fracture, there is adjacent bone marrow edema, which appears bright on STIR, fat is suppressed. So that is how you can differentiate between edema within the bone, right? Marrow edema within the bone versus fat, because fat is suppressed. So edema shines out. And there is edema typically along the distribution of the fractures, that is along the sacral ala, parallel in the paramedian aspect, and a central horizontal crossover fracture. So this is what is your typical H sign or Honda sign, seen on what modalities? Either a bone scan or an MRI, usually a STIR MRI. These are also considered to be the most sensitive modalities for the detection of sacral insufficiency fractures, right? So this is a very typical Honda sign or H sign, and therefore this is seen in what? This is seen in sacral insufficiency fractures. Multiple myeloma usually presents with round punched out lytic lesions, usually involves the axial skeleton, but not usually the sacrum. It involves the skull vault, raindrop appearing skull. Osteomyelitis, right, will not usually uncommonly affects the sacrum, usually does not, must presents with signs of fever, right, infections, right, so like fever, raised CRP, total elevated count. So that is how osteomyelitis would present. Transient bone marrow edema is bone marrow edema, would look like this, but usually does not again involve the sacrum, whereas it involves the vertebral bodies and the ribs and the extremities, usually does not involve the sacrum. So this is the H sign or Honda sign in sacral insufficiency fracture, seen on STIR MRI. It could also be seen on an MDP bone scan. Yes. So identify this investigation. What is this investigation now? If you look at this image very carefully, you're able to see some amount of contrast. And if you look alongside it, you're able to see a lumbar vertebral body. This is probably the L5. And this is the S1 with the intervening disc. You're able to see the sacrum on the lateral aspect. So what is this loop of bowel filled up with contrast? This is usually the colon, mostly the sigmoid colon, or this is the sigmoid colon, rectum here. So rectum here, and this is where the contrast is going into the anal canal, where it is being actually passed out, right? So there is a technique which is called micturating cystourethropography, which is used to visualize the bladder and the urethra while the patient is micturating. While this is a investigation which is used to visualize the sigmoid colon, rectum, anal canal while the patient is defecating. So this is what is called as a X-ray evacuation proctogram or a defecogram. So this is what is an X-ray defecogram. Well, why is an X-ray defecogram done? So X-ray defecogram is done to look for certain abnormalities in the pelvic structures during the act of defecation. So it can be used in cases in patients who have chronic constipation, right? It could be done in evaluation of bowel incontinence. It could also be done in suspected cases of pelvic organ prolapse, right? So these are a few indications in which a defecogram can be done. So this is an X-ray defecogram. what is better, right, and is more commonly done these days is an MR difficography, whereas an X-ray, difficogram can only show us the bowel. An MR difficogram, because of its high contrast resolution, greater imaging capabilities, can show us almost all the pelvic organs. So the line is drawn from the tip of the coccyx to the pubic bone. This is called as the pubococcygeal line, and the greater the descent of pelvic organs below this line, greater is the degree of prolapse. So if the bladder prolapses down, it is cystocele. If the rectum prolapses down, it is rectocele at the time of defecation, right? If the uterus and the vagina, prolapses down, this is uterovaginal prolapse. So that is how it can be interpreted. There's another very common indication for which an MR difficogram is done, and that is done to look for the anorectal angle. Remember, so see here, this particular muscle sling is what is called as the puborectalis muscle sling, and because it goes along the posterior aspect of the rectum, right, this angle is measured, which is called as the anorectal angle. It is an angle measured by a line drawn along the lumen of the anal canal and the posterior wall of the distal rectum. At rest, usually this angle is between 90 to 110 degrees. At the time of contraction of the puborectalis, just see, if the puborectalis is going to contract like this angle is going to decrease. So this angle is going to decrease further. It is going to become more acute, right, at the time of contraction of the puborectalis sphincter or the puborectalis sling. Whereas at the time of defecation, because the fecal matter has to pass through, right, from the rectum into the anal canal and is expelled out, right, the puborectalis has to relax. And if the puborectalis has to relax, then the angle will become more obtuse. And you're able to measure and see this angle very well at the time of doing this MR difficogram, and that is what is the greater utility of MR difficogram as compared to an X-ray based difficogram. So if you look at this particular image, right, it looks like it is a barium enema, because you see the contrast within the colon and the rectum, but barium enema is not there in the option. What is there in the option is barium swallow. This is definitely not barium swallow, because you are able to see the lumbosacral spine there. This is not a CT image. This is not an MR image. This is therefore what is left X-ray difficogram. Therefore, what is left is an X-ray difficogram. So this is what is a conventional modality. The indications and specific pointers to look for in X-ray difficogram, we have seen them. We have also discussed MR difficogram, right, and the additional utility that it brings, right, so that's to diagnose the pelvic organ prolapse or the anorectal angle and what happens at rest, contraction, and at the time of defecation is the anorectal angle. So what is this? This is nothing but an X-ray difficogram is what is the answer to this particular question. Well, friends, all of us have witnessed the valor and the bravery of our armed forces recently in the form of Operation Sindoor. If you look at the reasons for success behind this great Operation Sindoor that the Indian armed forces together carried out, it was thorough preparation before they went into it. It was strong backing, not just of the government, not just of the people in charge, but also from the entire country. Each and every one of us was strongly backing the army. That added to their confidence, and that is what led to them having that utmost confidence and self-belief. Well, friends, what has worked in this Operation Sindoor, if you think about it, is also going to work. It is the same things which are going to also work and help you in your Operation NEET PG in the next few days. Thorough preparation is what you have done throughout all these months and the last year or so, going through all these videos, test series, Q banks, and all this stuff. We are doing that right now, right here, when you're going through all these recall videos. You have the strong backing of all your concepts that you have understood all through this preparation time. You have the strong backing of all these learnings and clinchers and concepts that we have discussed together when we went through all these topics. All you need to do now is to have that confidence that you are up to it, you're going to crack it. Have that self-belief, go into the exam and crack it. Definitely, you're going to be successful in this particular exam. I wish you all the very best. Thank you very much.